Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm hospice nurse Penny.
And I'm Hallie, hospice social worker.
Today, it is going to be just us. We are each other's guests, and we are going to be talking about medical aid in dying, aka death with dignity, and then we will be following that up with our season wrap up.
I
So
know.
first, let's hit the medical aid in dying. Actually, let's start with this. When we spoke before last year on your podcast, I talked about medical aid in dying, and you told me that you prefer the terminology of death with dignity. Now, I, being a longtime hospice worker also, and probably paying attention to the man, felt that the concern that many hospice agencies have that death with dignity kind of implies that people can't have a dignified death on hospice, made that kind of not as popular of a term. But you had a really great take on why we should call it death with dignity. So I want you to talk about that.
Well, it's funny you say that because it has been a while since we did that podcast. And if people do want to know, I've never mentioned it on here, but my individual podcast is Someday We'll All Be Dead. And yeah, my opinion on that has varied actually since that conversation.
Now it's different, right?
Well, not fully. So the reason that I had major concerns initially, first of all, the law in Washington state and many states actually states death with dignity law. So that's number one. Number two, though, is medical aid in dying can really sound similar to medical or physician assistance in dying. And I felt like it really lent itself towards the outcry of people that don't agree with this law anyway, which is that you're euthanizing people or it's assisted suicide, etc. And so medical aid in dying really felt more like that to me initially.
Mm-hmm.
Since then, since many conversations, and also because not federally, but like across the states, medical aid in dying is becoming more of the preferred term for language in manuals, in conversation, whatnot. I've started to accept that it's not going to be death with dignity, and I totally heard your point. Hospice care should be death, including dignity,
Mm-hmm.
anyway. So I get that. I do still waver with myself, and especially after we'll get to our guests here wrap up in a moment, but especially after hearing that the law in Canada is called medical assistance in dying. So again, I feel still that confliction of, is it too close to suicide, euthanasia, and the pushback that we get anyway?
And I remember when it was called physician assistance in suicide or physician assisted suicide,
Yeah.
and hated that. Have always hated that. It
Mm-hmm.
is definitely a stigmatized way of looking at it to say that it's assistance in suicide. And I guess so. One of the most important things that I want people to know about it, and I get asked about it a lot, is that we don't consider it suicide. Suicide is not what goes on the death certificate. What goes
Mm-hmm.
on the death certificate is the person's terminal illness, whatever actually caused their death, because we consider that the cause of their death, and that life insurance policies will still pay out. That's a major question that I get.
Mm-hmm.
Will
And
life
that is
insurance
written into
pay?
the law.
Mm-hmm.
So yeah.
Yes. Yeah.
Yeah, so let's kind of backtrack and go just kind of review. I want to review how this law came about. So this actually started in Oregon. They beat us to something back in 1997. So this isn't new. This is something that's been around for a long time, but they really were the first state to pioneer legalizing this assistance in terminal patients. And we'll get to the criteria in a moment, but terminal patients being able to request life-ending medication. That ultimately is what this is.
And was Dr. Jack Kevorkian the impetus for that? Was
You know
he
what?
the
I imagine that he probably had some influence in the thought of we need to have something different, because Obviously, if people remember, younger people might not remember
Yeah,
Dr.
some people might
Kevorkian.
not know. I mean, I feel like everybody knows who, because they even use Kevorkian as a verb sometimes.
Yeah. So
Like,
he actually physically assisted people. So he
Mhm.
would have an IV, he had a machine. Funny enough, it was to me similar to what looks like for the death penalty cases, but clearly the patient was willing and they were being videotaped and consenting and all that. So very different in that aspect. But they had a machine with the formula, and he would push the buttons and and give the medication, which is very different than what the law is now. But yeah, I wouldn't be surprised if that whole he ended up going to jail because it wasn't
Mhm.
legal. So
Yeah.
if people want to look that up, that was a whole saga in U.S. history.
Mhm.
So Washington State followed up, but not. I always thought in my mind it was only a year or two later, but we actually didn't do it until 2008. So almost a decade later. And that was Initiative 1000. And we're focusing on Washington because that's where we both are. This is the law that we're familiar with. And up until last year, 2023, the law had a 15-day waiting period, then a second 48-hour wait for the prescription after you were done completing all the things you needed to do. And then if everything lined up, you could actually get it done in 15 days, but it was pretty tight. You have to have the two doctors. You have to have, they both have to agree that you're qualified. Go ahead.
Right. And determine that you are of decision-making capacity
Yes. So
and that
you
it's your
have,
decision,
yes.
right? Yeah.
Yeah. So you have to have a terminal illness, but it can't just be any terminal illness. You have to have a terminal illness with a prognosis of 6 months or less.
Right.
We'll come back to that because I have more to say about 6 months or less, but
Yeah, me too.
that part hasn't changed. So two qualified doctors deciding and agreeing that you have a prognosis of 6 months or less, that you are an adult over 18, that you are able to request this yourself with no undue influence, that no one's influencing you to do this,
Mhm.
and that you're able to self-administer this life-ending medication. Now, we'll also come back to self-administer because there have been some changes over the years, but basically you have to be able to either push a button or swallow this medication. Then in last year, 2023, they amended the law. I'm frankly a little bit surprised that it got amended, but I also personally think it needs to be amended even more. So the new amendment, the wait period went from 15 days to 7 days. Now, people that don't have a terminal illness or haven't been through this with their loved ones, 15 days might not seem like a very long time. And what was the big deal? So, Penny, I feel like you can definitely speak to this. You've had patients come on with a really quick decline.
Yeah, so I had a patient who wanted to do death with dignity. He had liver cancer, and he was in the process of doing the paperwork and was in that time period where he needed that 15-day waiting period. And part of the symptoms of liver cancer, one of the symptoms is cognitive impairment. He became very confused, agitated, and was unable to complete the process, like
Yeah.
wasn't able to be determined to be eligible to be able to
Yeah.
complete the process. And he ended up so agitated that we had to transfer him to a hospice care center and do palliative sedation for him.
Mm-hmm. Mm-hmm.
And his husband was so distraught. He just always, every day I went to see him, he would say, this is exactly what he did not want to have happen. It was
Yeah.
just horrible for him. And in the end, we sedated my patient until his death. And I couldn't
Mm-hmm.
help but think, what's the point? What is even the point? He's got
Yeah.
zero quality of life now. He is
Mm-hmm.
completely unaware of anything that's happening around him. He's just, being allowed to die naturally through this period of time, but heavily sedated. It didn't make sense to me. So yeah,
Yeah.
that was a really horrible experience
Mm-hmm.
seeing that.
Well, let's take a break just real quick and talk about palliative sedation. So, We've mentioned that a couple times during this season, and we haven't really stopped to talk about it. I know in our agency, we're very careful around the use of that language, that it's
Mhm.
not necessarily a menu item that people just ask for, but that we
Right.
are treating symptoms up until the point of sedation if needed. And also possibly respite palliative sedation where we're giving people a break.
Yes.
But can you
Yes.
elaborate a little bit more on the nurse's side of things as far as what is palliative sedation and when would you use it?
Yeah. So first of all, when I started in hospice like 19 years ago, we called it terminal sedation, and
Mm,
that was really not a very good name for it because it implied that we were putting people to sleep to end their
mm,
life, and that's not what we were doing. Palliative sedation is usually done for people who are terminally agitated. That's when we mostly do it. It can be done for intractable pain, but usually it's terminal agitation. And we have done everything that we can possibly do to try to manage their symptoms, and nothing is working.
mhm,
And if a patient is asking for palliative sedation, then they're not qualified for palliative sedation, because somebody who is needing to be palliatively sedated is they're just unable to, they're so close to the end of life, that they can't even communicate that need to us anymore. They may have talked about it ahead of time, like, if things get really bad, I just want you to just put me to sleep until the end. But
mhm,
typically, when we're making a decision, which is, like you said, a very difficult decision to do palliative sedation, the person is usually days away from the end of their life. I haven't ever really seen it go on longer than 5 or 6 days at the most.
yeah,
Usually it's just a few days. They're just really right at the end. But
mhm,
it is almost always for, terminal agitation, and, the drugs that we use are like a benzodiazepine infusion that we can do, like a Versed infusion, which is used for conscious sedation. If you go get a colonoscopy, oftentimes they'll give you Versed and fentanyl. Um, we can also use phenobarbital for
mhm.
palliative sedation, and propofol, not very common, but I've seen propofol used also for palliative sedation.
Good.
But
Thank you for that.
mhm,
It's been on my mind that we probably need to expand the definition of that. Sometimes
yeah,
I think we start talking in our medical jargon and forget to explain things.
yeah. And the intent is not to end the person's life, but there is something called a double effect, which means that in the
Yes.
process of sedating somebody, it's possible that death could occur as
Slightly
because of
faster.
that. Yeah,
Yeah,
slightly
yeah.
faster, yeah. Not
Perfect.
because of that, we'll say slightly faster, and the cause of death, just like with death with dignity or medical aid in dying, the cause of death is still the person's terminal disease.
For sure. So we'll backtrack to where we were before I derailed us in this conversation. So the 2023 amendment to the Washington law that changed from 15-day waiting period to 7-day waiting period. And during that waiting period, they also removed that extra 48-hour window. So it used to be that once you did your final oral request, that you would have to wait an additional 48 hours before you could get your prescription. That could have been done within the 15 days if you were able to line up everything perfectly. Now you don't have to worry about that at all. It's just 15 days from the start of your oral request is used to be, and now is the minimum 7 days waiting period. So when I say waiting period, I just like to clarify that 7 days is from your initial oral request, but it doesn't mean you're going to get all the steps done. So you have an initial oral request, you have two different doctor consults, you have a second oral request, and you have a written request. And even if you get all of those things done, even if you get your prescription at the pharmacy, even if you pay for it and pick it up, which we'll come back to that too, you don't ever have to do it. It is a minimum wait period. It's not a you have to do this after 7 days period. So that is
Yeah,
the wait
that's good
period.
to know. Hey, I wanna say something about the oral request too,
Yeah.
because when we say you first need to make an oral request, that kind of sounds like this formal thing, right? And in reality, all you need to do is state your intent to your provider. And if they document that in their medical record, it could even be just something like, Mrs. Smith says that she intends to do death with dignity. You can request a copy of that record, and that counts as your oral request. So it's not like this formal thing that you have to do. It's just basically saying I'm going to do
Or
what
you're
you does with
interested in
dignity.
it, or interested in
Yeah,
information
or
on it.
yeah, I'm interested in information on it. I'm thinking about it. That can count as your oral request.
You can say, I want to start the clock on my request, but make sure, as Penny said, make sure that it gets documented, because if it didn't
Yes,
get documented, it didn't happen.
correct. Mm-hmm.
So getting a
So
copy
go
of your
write
records is
that
good.
down.
Yeah.
Write that down. I'm going to
And
tell you something. You
especially
need to
with
write
my
down.
chart. Yeah. Especially with my chart,
Yeah,
that's
yeah,
helpful.
yeah.
So you can get a copy
Mm-hmm.
yourself, but make sure that they write it down. And if you're only using my chart, you don't get a hard copy, or you get the aftercare summary, make sure you look and see, because you can stop right there and say, hey, we did talk about this. You need to make the note in
Put it
this
in there.
chart.
Yeah, they can
Otherwise, you'll have
edit
to
it.
start your clock again, which for
Mm-hmm.
some people might be fine. You might have plenty of time. But if you have a super aggressive, late diagnosed situation, time might be of the essence.
Yeah.
Now, the new change also includes that it used to be only MDs or DOs, certain degrees of medical doctor, could do this. Now it can also be ARNPs, which is advanced registered nurse practitioners, or PAs, physician's assistants, which is really, that was targeted at the more rural areas that don't have access to all the
Mm-hmm.
doctors, like that are only MDs.
Right.
Plus, most of the time, your doctor might be an ARNP or a PA, and they know you better. There might be an
Right.
MD overseeing the clinic, but they're not your person. So,
Right. And if you're in a rural area that has, like, for example, a Catholic organization, and that's the only healthcare organization that's in your area,
yeah,
they're not going to do it for you. So, yeah,
yeah,
good to be able to
yeah,
have more
that's very
options.
important. And then, like I said, the extra 48 hours was removed. So, and things to note about this law. So, anyone can opt out of the participating. So, as Penny was indicating, some religious based organizations, whether it be doctors, clinics, hospitals, pharmacies, even, anybody has the right to opt out of this. It's not a requirement, even though it's a law that people do have the right to access it. Clinicians have the right also to opt out. And so it's important when you're considering this to ask your whoever's helping you, your clinicians, your hospital, whatnot, how much of it will they be involved in, or are they willing to? Now they should at least take a first oral request, like document that you noted it, but they might not be willing to do the additional steps.
They actually have to have a policy now. The state requires them to submit a policy. So every in Washington, every healthcare organization is supposed to be putting a public policy about what they will and won't do. And they actually provided a document for us to fill out that says, we'll do this, we won't do this, we'll do this, we won't do this.
Mm-hmm.
And so it should be publicly available to find that out.
Yeah, I imagine if it's not already, it will be pretty soon. I know that was part of the new change as well.
Mm-hmm.
There are alternate forms of ingestion. So we talked about people having to be able to self-administer. So the normal route, this medication is compounded. It's multiple medications. It's changed over the years, and it does continue to change. Right now, it's about 4 or 5 different medications, and it comes in a powder form, and you add a liquid to it, and you shake it up, and then generally you will ingest it by drinking it, by swallowing it. So one of the things to consider is, how is your swallow? Are you able to swallow? Are you having issues with nausea? You do get some pills beforehand that are antiemetics, so anti-nausea medication, and to relax your system. But that is a concern. So we want to make sure, for people that have difficulty swallowing, know that if you have a feeding tube, then you can actually have that ingested with a feeding tube. You just have to be able to push the plunger. If you have the ability to swallow, but let's say you magically qualify and have ALS, that happens. Challenging, because ALS usually comes with complications of cognition that you're not able to do it. But I have had people that don't have that symptom. They have other issues, and so they're able to ingest it, but they can't hold it. So you are able to have someone hold a glass with a straw, as long as,
Mhm.
again, you're able to actually suck it down and swallow it. And lastly, there's the option of the Macy catheter, which is
Nope,
a
nope,
rectal.
nope. I have to stop you. The Macy catheter is not an option. A rectal,
Ah,
Foley catheter or a Foley
yes,
catheter inserted rectally, but the Macy catheter is too small.
you are
It w
right. I am glad you brought that up. I totally forgot about that. Yes,
it
rectal
has to be
catheter.
a large, like, I think I wanna say like a 16 French or no, an 18 French, I think. It has to be an 18
Yeah,
French.
yeah, I think you're
Yeah,
right. Yeah,
pretty big
because of
rectal
the
cath
amount of medication that you're putting there. But rectal catheter,
Mhm.
yes, thank you for that.
Yes.
I always forget that. That's why we have nurses to tell me these things. So yeah, rectal catheter, it's not necessarily the best option for this, and it may take a little bit longer. That's another challenge. But again, it's an option that may be available, and you have to be able to push the plunger to put the medication in.
I think I would opt for that though, myself, because the medication burns going down,
It doesn't
and
taste great, and it
yeah,
does burn.
it burns, and they can follow it with, like, sorbet, apparently, like, you can't do a milk product after, but you can do, like, a sorbet to kind of but I would rather just, like, give it to me rectally. I don't wanna have to swallow it if it's gonna burn. I don't want my last drink unless it's an alcoholic beverage, I don't want my last drink to burn going down.
Well, funny you mention that. You can actually have it with alcohol, although I
Mhm.
don't know that I'd recommend that you drink it with alcohol, probably as a chaser. We often use popsicles to kind of freeze out your mouth and throat, and mixing it with simple syrup does tend to help a little bit.
Mm.
But you're right, it is a challenge for burning.
Yeah. Hallie, you've been present,
I
correct?
have, multiple
Yeah.
times. Yeah.
Are you gonna give us a story? Because I think that people want to know, like, what is it like when a person does this? And maybe you have
hmm
more of the technical stuff you wanna go through first, but I know people are gonna wanna know what is it like? And people always will ask, "How long does it take?" And death takes
Yeah.
as long as it takes.
Well, that's still true. Yes,
Yes.
I will give a story here just shortly. So, lastly, as mentioned previously, rigorous criteria, they are ongoing. Like competency, like Penny mentioned, we continue to ask. You still have to be able to, up until the point of ingestion, you have to be able to cognitively say. So, unlike our previous guest, Javita, we do not have a law that says you can make this arrangement with your doctor and they can help you with it, or someone else can help you with it if you become incapacitated. That's not, nor I doubt ever, going to be a thing in the US.
Mm.
Um, the 6 months for hospice, 6 months or less prognosis for hospice, that's very different than the 6 months or less for the death with dignity law. So I want people to hear me say this,
Hmm.
because it's confusing, right? You come onto hospice and you're like, well, they told me I have 6 months or less, I should qualify for this law. Not necessarily. So, hospice 6 months or less, it is likely if your disease trajectory is this, but it's a little squishy. We have a bit of a gray area because there can be things like pneumonias or falls or UTIs, things that might bring people on a little bit earlier. And that's why we say you might stay on hospice for a year or 2 years, whatnot. We still have to mark that you're qualified and that you meet those criteria every few months, etc. Penny certainly could talk to that quality measurement and certifying people, recertifying people. But the 6 months or less for the death with dignity law, at least the people, the doctors that I've worked with, that is a much tighter, much more certain 6 months or less. That's what I've found. So talk to the docs, just be aware if it's something that your loved one or yourself is interested in, then there might be a little more stringent criteria for the 6 months or less part. And then just because someone gets a prescription doesn't mean that you have to take it. It is not free.
Right.
Insurances do not cover it. Currently, it is about $800. It used to be way more expensive. It used to be more like 3,000. So,
Mhm.
um, but there is also, there are groups in our state, and I'm sure other states, that have foundations that can help people that can't afford it, because it is a justice issue. As a social worker, I certainly feel that $800 is out of reach for people sometimes. But there are foundations that can help people. So it's expensive, bottom line. And then the last thing to know is an interesting one too. You don't actually have to tell your loved ones you're doing this. It's recommended.
Mhm.
We want you to. And we want you to, not because we want you to be judged or to have to hear you're dying by suicide, but because we want you to have that support. Not only support for you, but support for them afterwards. If you were going along and you're pretty early on your journey in that 6 months or less, and you die suddenly,
Yeah.
and you haven't had that more prolonged transition to dying, it's going to be a little harder for your loved ones to grieve, especially if they find out later. We wouldn't tell
Yeah.
them, but we encourage you to tell them, but you're not required to. So that's something to know. And yeah, as Penny said, it's not on your death certificate. So the thing that's on your death certificate is your terminal illness. Whatever you're dying from, that is what you're dying from. So there has been an increased use in the use of this, not only accessing it and getting the prescription, but actually using the medication. We've definitely seen an increase, especially in this last year or two, I'd say. People have been doing it since I've been working in hospice for this whole last, 10 years, 9 years, but it definitely has increased. And I think part of that's just awareness that more people that other people know are doing it, or they've heard about it, or they've heard about the law change. So it's interesting because sometimes it's a challenge. People come to hospice right at the end and they come to us saying, we want to access this and we want to access it right now. And there are steps. We can't skip over the steps.
Right. And there are more hospices that are getting involved with this now too. I know that. Let's talk about exclusions though. Why are some people unable, even though they have a terminal condition, why are they unable to use the death dignity law?
Yeah, well, of course, the example you gave was great. So someone might have started the process and then become incapacitated or have a change in condition that doesn't allow them to utilize it. They might not be able to swallow and not have a feeding tube. And also, maybe they had radiation in their pelvic area. And so a rectal catheter would not really be advised because you're not going to have the absorption that you would in the rectum. So those are kind of the physical aspects. And then if you have a disease such as dementia or Parkinson's or Huntington's or mostly ALS, if you have a disease that by the time you get to 6 months or less, you are not able to cognitively or be mentally competent to ask for that medication, then you are not able to use it.
Right. And for those people, there is an alternate thing that they can do that I know End of Life Washington is helping with, and that is called VSED, voluntary stop eating and drinking, where a person with dementia, once they get their diagnosis, can make a decision to stop eating and drinking to end their life. Typically, when they do that, it takes about 7 to 10 days before death happens. And there are ways that, they can be supported through that. Sometimes I wouldn't be able to do it because I'm a foodie, so I would never be able to do that. I think also that trying to decide when the time is right is going to be a challenge because as you start to decline with your dementia, will not recognize that decline. And it would be really harder to know, like, when is the right time to do this? So that would
If
be a
you're going to
challenge, but
choose
that is
VSED,
an
you're going to
option.
leave a lot more life on the table because you have to be able to make that decision consciously. And there are a lot of steps. We definitely suggest more support, not only for you, but for your family. A lot of hospices won't take someone that just has VSED until they're several days in and are starting to be more unconscious because they don't technically qualify.
Right. They don't qualify. Yep.
And then the other thing is that we recommend people make videos for themselves and their family members to watch to remind them.
Why they're doing it and that they want
why
to
they're
do it.
doing it.
And
because there is a point where you start to get confused, you start to get dehydrated. And I'm pretty sure we've talked about this. I know you've talked about it in your TikTok videos and Instagram videos, but when you're going through I haven't found a better phrase for this, but natural dying process without medical aid and dying, you don't really get dehydrated. You don't starve to death, right? Your body is shutting down and not wanting that. But when you're choosing VSED, you are doing a bit of that dehydration and neglecting to eat food and give yourself calories. And so there will come a point where you start to get more confused, or you may ask for fluids. And so you don't want your family to have to say you said no.
Right.
That feels
That's
very
where that
different.
video can come in handy.
For sure.
Yeah.
Yeah. So that takes a lot more support, a lot more preparation, I feel like. And it's a lot harder path. So, but it's available for people just much earlier upstream, because by the time you get to 6 months or less with those other ones, you're just not going to qualify. So, personal experiences. I've had the honor to attend several ingestions of the Death with Dignity medication over the years. And I say that it's an honor because I really feel that way. I've actually started to incorporate into my language as I'm talking to patients and family members, as I'm talking them through the process and what steps they need to take and what it looks like on the day of, that I'm telling them, even though you hear me say this in a very kind of clinical, straightforward way, I'm taking this very seriously. I don't take this lightly at all. And I know it's hard for you. And again, it's like we've talked about before, it's not my person, but I recognize the gravity of what we're talking about in the situation. So I just want to honor that space. And also, as a social worker, it's, in my prime directive, if you will, to honor people's self-determination. And so if this is what they want and they're eligible for it, then I absolutely support their choice to do it. And I would encourage people, even if it's not in their value system, and even if they wouldn't do it for themselves personally, that you're honoring the other person's choice for themselves. So what does it look like? So once you go through all the steps and you have your medication on hand, then the day of, you don't eat or drink really anything at least 4 hours before. You can have water or black coffee. Or popsicles. Like you said, you can have a sorbet right before or during to kind of take the taste out of your mouth, but be careful with sorbets because some of them do have dairy in them. It's sneaky. So that's why we would just recommend those popsicles on hand. Many places, it depends on their policy, so make sure you talk to your hospice. If you're working with one, I recommend you work with one so you have that extra support, but you don't have to be on hospice to do it, but I would definitely recommend it because there are 4 times that you have to document for your prescribing doctor to notify them. They do keep track of the times for the law. So that part is tracked, just the times to make sure that everything is working the way it's supposed to. So no food or fluids for 4 hours before. You take your anti-nausea medication about an hour before you're going to ingest your medication. And during that time, I always encourage families to have a plan. Are you going to watch your favorite movie or listen to music, or do you not want very many people? We've talked about all of these things ahead of time as who do you want there to be with you? Or do you not want anyone to be there, and what that's going to look like. And once we get to the point of ingesting the medication, then we're going to make sure that you're in a more upright position, head up, as elevated as we can. So hopefully you have a hospital bed. That's ideal. But I have had people take it in a recliner or in a bed that's just propped up with pillows. But we want to make sure that you're helping gravity, right? You're going to use gravity to your advantage. We do not want you to take a very expensive nap. In the entire time I've done this, which is many times, and with everyone else that I've worked with that has participated in this, only one time have I ever had someone actually regurgitate the medication. I think it was kind of a post-death reaction because they were gone right away or right then, luckily. but I've never had anyone actually throw it up and not die. The end result is death. You are taking life-ending medication. So once you take the medication, you have to drink it in about 1 to 2 minutes. It's only about 2.5 ounces of fluid. And once you drink it, you want to drink it in that couple of minutes, because in about 5 to 10 minutes, usually closer to 5, you're going to become sleepy and you are going to go into a coma. And so if you don't get all of your medication down, again, unlikely. I think as long as you get the majority, 90% of it down, it's going to work. But we
Mhm.
want to make sure you're paying for this. This is what you want. We don't want you to wake up from a very expensive nap and be even more mad that you're still alive. So drink all that down, 1 to 2 minutes. It's more than enough time. Usually we'll have you drink with a like medium-sized straw, so get it as far back in your mouth and not doesn't taste good. We'll have that popsicle, or maybe I've had someone take a shot of scotch, afterwards, do a cheers with their family. And then you're going to relax and you're going to go to sleep. And at that point, the normal, quote unquote, active dying process is going to happen. It's just going to happen a lot faster than it normally would. So in that first couple of minutes, when someone's asleep, you're going to start to see those breathing changes. You're going to start to see the color change. So you may see their lips turn blue. Obviously, they're going to be completely unconscious. So there's not going to be any pain involved in this. They're completely comfortable. And then the breathing changes can be anything. I have seen some of the guppy breathing, so kind of the kind of breathing. And very, very, I would say 99% of the time, you're going to have that apneic breathing. So you're going to have those pauses, and then you're going to have the kind of gasp after a pause. So the we warn people about that because, again, scary, right? Even without medical aid and dying, when you hear those breathing changes at the end of life, it can be scary. And so you want to reassure
I
people.
call that an expiratory sigh. That's what I refer to that now, because it sounds like a moan, and I used to think it was a moan. And not everybody does it, but when I had patients that were doing that, I would give them pain medication and I'd think, why isn't this pain medication working? And then I just came to realize it's just a noise that they're making. And so now I think of it as more of a sigh than a moan.
I don't usually hear that. I know what you're talking about. I don't usually hear a noise as much as just the breath. And more of a gasp, like your electrical system in your brain has said, hey, you forgot to breathe. And so it's just a reaction. And so I'm reminding people, like, hey, the body's shutting down. It's going to say you forgot to breathe. It's not painful. They're not in pain. And then that process, like you always say, death is going to take how long it takes. You're taking this medication, usually on average, your 1 to 2 hours is pretty standard. I've seen it go longer, though. There are a lot of different scenarios where maybe you have tumors or other things going on in your gut that are going to slow your gut down. And so that digestion, it slows everything down. So sometimes it will take 7 hours, even with the new medication, it can take longer. People with heart conditions, anecdotally, almost always 15 minutes to an hour. I've also seen people that were healthy otherwise, had a tumor in their brain, and also had pain significantly for quite a while. So had a pretty good history of opioid use for that pain control. And so that also took quite a long time. I think that one took around 9 hours.
Wow.
So we do want to prepare the family, like on average, it's going to be fairly quick. And also you need to have a plan, because this can take longer, and it's going to take how long it takes. I can't predict. I can tell you my experience. I can tell you the things I've seen, but it's not always the same. Every body has a different process.
Just like with a natural death on hospice.
Yes.
We don't know until it happens,
Exactly.
We can give you our best guess, but even when they're taking a medication that is meant to end their life, we still have to guess. We still don't really know. I did hear a doctor that said he knew of one that went for 14 hours, which was quite a long time.
Yeah. I mean, really long time ago. It's been I want to say right when I started around that time, there was one person that took 23 hours.
Oh,
But
wow.
that medication is not even the same medication that we have anymore. It's not the same properties and not the same medication concoction. And I don't know what was going on with that. I don't know if they were just really early in their process or what, but that's an extreme outlier.
Okay, so you know how we know that people who are dying a natural death on hospice can sometimes, it seems like, choose their time and wait until family members leave before they die? I wonder if it's kind of the same thing. It seems like people would probably tend to more even want to hold vigil with somebody who was doing death with dignity.
Hmm.
And I wonder, like, is that what caused somebody to stay longer? Because people were vigiling, and had they left the bedside, maybe the person would have died. You know what I mean? Kind of
Yeah,
makes you
it's a good
wonder.
question. I have had some where after a while I've had them rotate out of the room, or just give some time in and out if it's taking quite a long time. But that's again pretty unusual and pretty, I would say 75-80% of the ones I've attended have been right either an hour or even like it seems like 5 minutes, not even 5 minutes. Um, so yeah, no, that's a good question though. We certainly do see it with a non DWD death.
Yeah. Yeah, all the time.
So yeah, that's how it is, and then everything else is just as we would normally do. So we tell people you can take your time. There's not an emergency. If you want to spend time with your loved one, you certainly can. Um, and yeah, then we call the funeral home just like we normally would.
And currently it's available in how many states did we decide?
Oh,
10?
yeah, it's 10 states and plus Washington, D.C. So currently,
Okay.
as of this recording, so that is May of 2024, it is Oregon, Washington, Maine, New Jersey, Vermont, New Mexico, Montana, Colorado, California, and Hawaii, and Washington, D.C. So if
And let's talk about Vermont and Oregon, who recently both passed laws that you do not have to be a resident of their state in order to use their death with dignity law there. So that is a huge deal, because there are many, many people who live in states that don't have legalized medical aid in dying,
mhm,
and have to go and travel, uh, and can now, and can go to Oregon or can go to Vermont. Previously, they couldn't. So, um, there was a story probably 10 years ago or so of a young woman with brain cancer who wanted to do it. And do you remember, who I'm talking
she's the one that
about?
went to Oregon. She was
Yeah,
one
she
of the
went to
first.
Oregon. She became
Yep.
a resident of Oregon. So she had to
Mhm.
move to Oregon. And I met her husband at a
Mm,
conference last fall, and he still advocates for medical aid in dying. He does a lot of work with Compassion and Choices.
mhm.
And, he talked about her and how I want to say her name was
Is it
Brit,
Brittany?
Brittany. It was
Yeah.
Brittany. Yeah. Yeah, and they had to, like, literally pack up and move to Oregon and become residents of Oregon, which took a long time, so that she
Yeah.
could actually access that law. And now, thankfully, for people who don't live in a state where it's legal, they can go to Oregon if they're on the West Coast, or Vermont if they're on the East Coast, and be able to do medical aid in dying.
One and still, the social work part of me is still like that's still a privilege to be able to even travel to that. So a lot of people
Yeah.
can't, physically can't, or financially can't, or they don't,
Yeah.
the rest of their family can't take time off of work. And so I'm super glad that it's available.
Hmm.
Um, I hope
Baby
that
steps.
someday it will be available more
Yeah, I
readily.
do too. I wish it was available federally. I think every state should have legalized medical assistance in dying, and the drugs should always be affordable. I don't foresee a time when insurance will ever pay for it. There's no way. They want the stigma that's going to be attached to that. Like, yeah, it's cheaper just to pay for the death with dignity meds than it is to let them go through their treatment for their disease. Not going to happen.
Not in our lifetime, anyway.
No, no, no.
Well, let's do our show wrap up, our season wrap up.
All
What
right.
great guests we had.
We did. We did. It's hard to I was thinking about, like, who is my favorite? And it's a challenge to think about who I think I really, really, really liked Katrina and
Yeah.
Faith and Dr. Faith, because their perspective was in such a different realm from ours,
Mm-hmm.
but the same too, like
Mm-hmm.
related,
Yeah.
really related, and they're both pioneers in what they do.
Yeah.
Katrina with the body composting,
Mm-hmm.
and Dr. Faith with vet hospice. It's amazing,
Well,
and
it's
of
hard not to
course,
continue to fangirl out about Andrew.
I was just gonna say Andrew, of course. I mean, I mean. Have to put the caveat on that episode that we completely talk about going off the rails. We were we were so far away from the rails. We were like going down the hill and down the road. Like we were nowhere near what we were intending on talking to Andrew about, but he was just so he's just so entertaining and just funny. Just so
Well, and we
funny.
did catch him in that weird space, so we ended up talking a lot more about social media, I think, than we normally would be talking about death
That's
and dying.
right. He had his first real hater experience. That's right. Yeah, he was
Mm-hmm. Mm-hmm.
processing. We were helping
Yeah.
him through that.
Yeah. Well, and it's probably a good thing. Oh yeah. Yeah. I was making little notes as I was thinking back about our guests and what amazing questions that Sam asked, our very first brave guest to be on with us.
Yeah, yeah. Our
Lisa
non
Paul with the Death Deck helping us have those great conversations in a really accessible and fun way to try to normalize death.
Yes. Yeah, I love Lisa. Talk about, yeah, another pioneer, like somebody else who has really um done something out of the ordinary and created that literally a game to
Mm-hmm.
try to get conversations going about death and dying. I love the death deck. Play it all the
Yeah, yeah.
time.
I can't wait for the grief death. That's going to be
Oh
amazing.
yeah, the grief deck. That'll be really great. Yeah.
And of course, Dr. Matt Tyler, our palliative doc, who's amazing on social networks and getting the word out there about palliative care, getting support earlier on before hospice. And I love his video about a banana and how it compares to hospice. Have you seen that one?
No, I haven't.
It's so great. It's like a banana is a fruit. So a banana is hospice and like it's in the fruit realm. So fruit is palliative care. I'm not doing it justice, but it's really good.
Well, he posted a video today on tube feeding that was
Mm,
fantastic. It was
nice.
so good. Oh, I wish I could remember what he said. That just really resonated with me. But it was, basically talking about, when you have to make that hard decision about putting a tube into somebody and why you shouldn't.
Yeah.
Tubes are great for people who aren't faced with a terminal illness, but when you have a terminal illness, you're not prolonging their life, you're prolonging their suffering.
Yeah, for sure. Moving to comfort feeding instead of force feeding is
Yes.
important to
Yes.
know, especially
Yes.
when we think about food as love, you know?
Mhm.
So then we went to Eileen Hollis, the very sweet funeral director from New York, as I recall.
Yes, she was fun. That was a fun interview. She's adorable. It's
And
just
and
bubbly.
again, really got the behind the scenes of what it's like to be in a funeral home and a
Yeah.
small family funeral home.
Yeah, looks as far from a mortician as you can possibly imagine. Just bubbly and cute and so knowledgeable too.
And Javita being so brave with her own terminal illness and giving us the information for Canada that she's willing to come on and share her journey just to make sure other people get the information. Love that.
Yeah. Yeah, me too.
Of course, we had to have your BFF on.
Of course, my bestie, hospice nurse Julie, talking about her new book. I'm just like wishing the best success for her with her book. And yeah, I just love Julie. I've known her since she got on TikTok. I think I was one of the first people that she reached out to. And from day one, we started texting each other almost every single day, voice texting each other constantly.
Well, I'm glad I finally got to meet her. It's a great connection you guys have and
Yeah.
great education you guys are putting out in the world. We need it. Of course, we have Steve. I miss working with Steve. He's so great. You'll have to go to Kenya someday and
He
visit.
he represented the hospice chaplain role perfectly.
Yeah,
Perfectly.
so well. I
Yeah.
mean, it just really, I think, instilled in people what chaplains and spiritual counselors do and what they don't do, more importantly, so that people aren't freaked out to have someone with that title come in.
Yeah, I agree. Too many people think that the chaplains have their own agenda to try to convert you to some religion, and it
Mm-hmm.
couldn't be further from the truth.
Of course, Esme, unfortunately, her audio was not ideal, but she had just such good information
Technical
about medical
problems.
records. Yeah.
Yeah, you got to have technical in at least once in every season. You're going to have your technical issues.
Well, we were still recovering with that with Celeste. Her audio wasn't the best either, but
Yeah.
she has so much experience and such a huge heart. And I absolutely, of course, love what she said about boundaries.
Yes. Yeah. Me too. Yeah, she's just been doing hospice for probably
Did you say
longer than
27
you and I.
years?
Yeah, almost longer than you and I put together. Not
Yeah.
quite, but yeah, a long time. She's just and so you know, really well spoken too. And I think people don't give CNAs credit when it comes to their knowledge, and they
Mm-hmm.
disrespect them a lot. And she just really represents so well for CNAs.
For sure. And then, of course, Dr. Faith Banks, our hospice
Dr. Faye.
veterinarian. How
Yeah.
incredible, like the entire time. I'm sure you felt it too. It was like, oh, yeah, that's just like on our hospice.
Mm-hmm.
It's
Yes.
so similar.
Yeah, it really was. It really was. She's
Love that. I
lovely.
hope that really expands. I'm hoping in the years to come that geriatric care for pets and hospice care for pets is much more expanded than it is now.
Yeah, me too.
And then our last guest, which I'm gonna get her name right. It's not Kate Spade. It's Katrina Spade.
Not Kate Spade.
ah, she
She doesn't make
she
handbags.
does not, and she's still alive, so that's important.
She
Um,
composts bodies.
she was amazing. She's another
Yeah.
one that's just so innovative and smart, and girl boss energy. I love it.
I love that she calls it body composting.
Yeah.
It is what it is. You know me, I hate euphemisms. I can't
Yes.
stand passed away, gone to heaven, celestial discharge, death, dying, died, dead. And I love that it's body composting because that is what it is. There's
Mm-hmm.
no secret there.
Yeah. Well, as we're coming to the end of season 1, Penny, how are you feeling?
Well, I wanted to first of all, I was thinking about this today too. The fact that we have 13 episodes in this season. That was your idea.
Mm-hmm.
So we're just a morbid crew. We gotta, and sticking with the death and dying theme, go for the
I
13.
wore my skeleton
Let's do your
necklace
skeleton
today. Yep.
necklace. Yeah, I feel great. I think it was really fun. Learning curve on lots of things. I think,
Yeah.
looking at our first episode and then going through and up to the last ones and going, we did get better at this. Even the opening, I
Yeah.
felt like as I'm watching the old videos, I see that opening, I'm like, welcome to the Death Happens podcast. I feel a little more comfortable on camera, and I think we've kind of we're going to hit our stride for sure next season, and I think we're on our way in this season as this season is wrapping up. How about
I
you?
think so. Yeah, I absolutely am so glad that we bumped into each other at the conference and got to know each other in person.
Yeah.
And that my boss, begrudgingly to me, told you about my podcast so that we can actually get to know each other. That worked out wonderfully. So I'm glad we can come together as this transdisciplinary informational session.
Okay, there's something else I thought about today too, and only people who are watching this on YouTube are gonna know what I'm talking about. But you do this thing with your hands that it just cracks me up. It makes me think of Mr. Burns on The Simpsons.
I do that a lot.
Excellent.
Yes.
Isn't that him? Excellent.
Yes. I am known for talking with my hands. You'd think I'm Italian or something. Excuse me. Well, that's hilarious. And yes, I'm sure many people have noticed that. We just want to make sure that we let the listeners know we welcome your feedback. We want to hear from you. So if you have suggestions on people that you want us to talk to, that there's subjects that you want us to go more in detail with, I mean, Penny has a ton of informational videos out there. I make informational videos about death and dying and hospice, but those videos on social media are very short. And so with this format, we can really get into more of the nuanced detail and really talk about the things that people want to know about and know more about, or explain things that happened. Hey, why did this happen to my loved one like this, or whatever? So let us know.
Mm-hmm.
You can find us on social media at Death Happens Podcast. Tell them all the social media handles, Penny.
Oh, I have to remember now. It's they'll be in the show notes. I think we couldn't be consistent. I think because Death Happens podcast was already used on
The email
YouTube, I
was.
think. The
Yeah.
email was, yeah. So
So
Death
it's
Happens,
definitely Death Happens Insiders at gmail.com. That is our
right.
email. And then you
Yes.
can find the Death Happens podcast on all the socials. Penny was gracious enough to put all that together for us and do all the amazing thumbnail art. I love it so much.
And it's available in audio on all of the podcast platforms, right?
Yes. And if you like it, please share it. Please,
Mm-hmm.
we have avoided doing this all season. So now's the time. Please subscribe or follow the show or share it with people that you think could benefit from it. That's how we're going to get this information out. It's not about us being popular. It's about getting the information out to normalize death. That's what we do.
Right. Yep. And look for us again next season.
That's right.
We're going to be back again. So
Season 2 coming.
season 2 coming.
Until then, remember to live.
Because someday we'll all be dead.